Hi, my name is Joseph Murungu. I'm the Deputy Director for Health Qual and also the Africa Regional Lead. I'm going to co-present this section with my colleague, Dr. Bruce Higgins, and in this module, we are going to focus on addressing the gaps in the cascade analysis and how to use that information to develop interventions that will address the identified gaps and um, lead to improve the desired improvements and performance. The specific objectives of this model focus on identifying the domains for categorizing the types of changes and interventions that facilitate selection of improvement, and also focusing on understanding the models that describe contextual factors that must be considered to adapt interventions into different settings. The third specific objective is focusing on identifying specific strategies that have been used with success to improve steps along the cascade and in addressing factors that are critical to advance along the cascade, specifically linkage and retention in care. So we picked up an example from Paris, looking at the strategies to improve the proportion of people living with HIV diagnosed, which is the first 95. And this example is summarizing the gaps across the cascade in terms of the proportion of clients that are tested and know their status. And some of the strategies that they put in place included free walk-in HIV test in medical labs without the required prescription, as it was identified as a key barrier, but also working with multidisciplinary teams, including pharmacists, to promote and conduct the HIV tests, and ensuring that they are express STI clinics where services including HIV testing can be provided. Data elements that are not in the cascade but we need to know include issues to do with engagement or retention in care. It is also important to reflect on time to initiation. And sometimes we focus a lot on viral load suppression without so much focus on the coverage, but for interpretation purposes, it is important to also review viral load coverage, more so with a focus on subpopulation groups, such as men who have sex with men, female sex workers, children, and even men now that are being left behind. The other key component that tends to miss out in the cascade, but that is important, is linkage to care, which we need to track over time. Using the root cause analysis tools highlighted earlier on, we should be able to identify the causes of losses and gaps across the cascade. And in this example, we're focusing on linkage to care. And these are some of the outputs from focus group discussions with patients and interviews with providers. At individual levels, some of the gaps are associated with stigma and discrimination, but also more importantly in the context of test and treat, issues to do with perceived health status, which leads to delays in initiation of treatment. There are also other issues such as the use of alternative medicine and spiritual beliefs as well that interfere with linkage to care. At healthcare provider level, issues to do with negative attitudes affecting the interaction with patients also lead to challenges with linkage to care. And then at health system and practice level, issues linked to client flow, poor clinic procedures and visit schedule may lead to challenges with linkage to care. But some of the issues would also be linked to overcrowding in the clinics, leading to long waiting times, few treatment and care points, compromising convenience and access to care, as well as challenges associated with the shortage of staff and inadequate equipment. And then lastly, just to highlight also contextual factors such as poverty. In some instances, then we need to provide supplements to ensure that the patients are linked to have access to the services. Long distance is another major barrier, as well as high transport costs. To address some of these challenges, we need to make sure that we have interventions at these different levels of the framework. So we need to address patient level barriers to enrollment in care, such as stigma and family support. We also need to provide interventions at community and at community level, targeting issues to do with stigma and discrimination, and we'll cover this later in this module. We also need to address structural barriers that hinder linkage to care. Immediate referral to HIV care following an HIV diagnosis is an intervention that has been demonstrated to work, as well as the use of case managers and patient navigators who provide escort services within the health facilities. The environment needs to be friendly and welcoming, and privacy and confidentiality also need to be assured. And the integration of services results in efficiencies and benefits both the health, the providers, as well as the patients. This is an example we picked up from Nairobi, which have, where they achieved 99% coverage on art. And their interventions were focused at various levels. So for patients with known HIV positive status and in care, but not on art, they had interventions including line listing of patients in care, but not on art, and sensitizing peer educators and case managers will provide escort and navigation support. But treatment literacy is also a very important intervention, so that the patients get to understand why they have to be initiated on treatment and why they need to adhere to treatment over time. For newly identified positive patients, escort services are critical to ensure linkage to care, and then follow-up of patients not showing up for their clinic visits using various strategies, including the use of mobile based platforms, as well as physical follow-up. For provider competencies, issues to do with the workload, as well as fear of losing patients. Some of the interventions included training and retraining of healthcare providers, routine mentorship and support, as well as the delivery of differentiated care models to decongest the clinics. Establishing county multi-sectoral HIV and committees was also critical, as a way of supporting treatment literacy, as well as the tracking and tracing of defaulters. For supply chain and strategic information, which are both critical components, it's important to set up commodity security technical working group that track progress across the whole supply chain cycle, but also making sure that capacity is built around focusing and quantification to improve accuracy. And then data quality assessments are done quarterly on all HIV-related data to make sure that we improve data quality aspects. And then the data should be presented in the form of HIV dashboards, which are easily accessible, but also making sure that the reports are granular enough to pick up vulnerable groups that might be left behind. So here we show retention through 18 months by sex and age group for community adherence club members in South Africa. And the key message here is that 88% of women and 86% of men are retained in care at 18 months. And then in terms of viral suppression, we also noted that 93% of women and 90% of men are virally suppressed at 18 months of care. Retention remains a big challenge globally, and various strategies, including the implementation of differentiated service delivery models, have been implemented to try and address the gaps in retention in care. And some of the strategies that can be implemented include the use of adherence club models, spacing of appointments, multi-month dispensing, as well as expanding clinic and pharmacy days and opening hours as well. This should also be complemented with improved tracking and tracing of defaulters, as well as making sure that stocks are available to facilitate the multi-month dispensing. Integration of services to ensure that clients have access to different services on the same day within the same facility is also important and convenient for the patients and the health workers as well. Other strategies include improving access to care through outreaches, but also making sure that we have contact with patients as soon as they miss an appointment rather than waiting for the prescribed 90 days until the next scheduled appointment. And this is where expert patients can come into play and support with tracking and tracing of defaulters. In Maputo, they implemented differentiated care to improve access to services. And some of the results and benefits they noted were centered around the reduction of patient waiting times, the reduction of frequency of visits to the health facility, but also additional benefits to the health workers in terms of a reduction in workload over time. And generally, this led to increased retention rates. This is another example from New York City, where they use the Undetectables Toolkit, an integrated and innovative program which aims to help each client achieve and maintain durable viral suppression. And through the implementation of this toolkit, they realized that 90% of clients were actually virally suppressed through the use of the toolkit. The Undetectables Toolkit targets the client and is coupled and complemented with strategies from primary care as well as case management. The toolkit includes key components such as behavioral health, adherence devices and support, peer support through support groups, as well as motivational interventions and subsistence needs. You can also then bring it all together, improving the whole cascade through packaging the materials in a change package. And this is an example of a change package from Vancouver, where there are various changes that can be implemented across the cascade. So there are changes to try for testing and diagnosis, and then there are also changes for linkage to care and retention to care, as well as viral suppression. And these have been demonstrated to lead to improvement in performance across the cascade. In Zimbabwe, we implemented a collaborative approach to improving early initiation of treatment as well as retention in care. This collaborative was launched and implemented in 27 high burden facilities in 3 geographic areas in Zimbabwe, which were prioritized based on the level of burden and performance across the cascade. The main aim of the collaborative was to treat 100% of adults and children diagnosed with HIV, including those newly diagnosed and those receiving care in pre-ART. This was launched immediately after the country adopted the Treat All guidelines. And the collaborative was implemented over a period of 18 months from 2016 to 2018. And some of the key findings that we picked up through the collaborative included a rapid adoption of the test and treat guidelines, leading to an increase in the proportion of patients that were initiated on treatment on the same day of diagnosis, but also a rapid decline in the patients that were in the waiting period or on the ART caseload. At the same time, we also realized that over 70% of the newly diagnosed clients were actually initiated on treatment on the same day, and an additional 10% were initiated within 7 days of diagnosis. And very few patients were not ultimately initiated on treatment by the end of the calendar month. And this included those that were not eligible for initiation or were being investigated for opportunistic infections. So stigma and discrimination continue to be a major challenge globally across various population groups that require HIV prevention care and treatment services. I'm going to hand over to my colleague, Bruce, to take it over from here. Thank you.
Thanks, Joseph. And as you've just heard Dr. Marungu say, the role of stigma is critical. And in this combined graphic focusing on both prevention, care, and treatment, we see the spectrum of areas in which we must focus if we're going to achieve our goals. And these include focusing on issues that stigma affects, including human rights, the support of laws, and of course, we need to focus on the identification of key populations so that they are able to comfortably access care and services across the spectrum. Very often, people feel that they are unable to address stigma, and so we wanted to spend a little bit of extra time focusing on things that can be done at the jurisdictional level. We know that stigma and discrimination still have terrible consequences. And the very people who are meant to be protecting, supporting, and healing people living with HIV often discriminate against these people who should be in their care, denying them access to critical HIV services, which then results in more HIV infections and more deaths. As UNAIDS has stated, to reach the end of the AIDS epidemic by 2030, countries will need to use the powerful tools available and hold one another accountable for results and make sure that no one is left behind. And this means that we must focus on a goal of zero discrimination. We also like to think of the fourth 90, and that on beyond viral load suppression is health-related quality of life. And this is something that's been described in the literature, as you'll see here, and so that we can make sure that we provide services that provide a positive experience and can help people who are suppressed achieve that good health-related quality of life outcome. I wanted to show you directly this figure developed by Laura Nyblade from the Health Policy Project at RTI, which shows how stigma acts as a driver on the cascade. And so we focus first on these four immediately actionable drivers, which are fear of transmission, awareness of stigma, attitudes, and the institutional environment or the system in which services are provided, which act directly on stigma, including experienced stigma, anticipated stigma, and a heightening of internalized stigma for people. This, of course, can result in avoidance of care, harassment in care, and refusal to treat. And that, of course, then leads directly to the effect on the cascade and our desired outcome of viral suppression. There are many strategies that can be enacted at the facility level to improve engagement in care, and these include offering a welcoming environment to patients, having a formal anti-discrimination policy and standard of care or a code of conduct, preserving privacy and promoting confidentiality of information, which is an area often cited by clients as problematic, sensitizing staff to issues of stigma and discrimination. Contact strategies are particularly effective in which people with HIV come together with those on staff and inclusive of key populations to tell their stories and experiences, which then brings a human face to the way in which the system functions and has a positive effect on improving the environment. And then finally, involving peers in the entire care process is a way in which to also make the facility more welcoming. So how would this play out at the jurisdictional level? So for example here, we would be able to focus at the national level, if you look here where the arrow is pointing at the middle box, where at the national level or at the city level, you would be able to oversee data collection related to stigma, provide training, and foster exchange between facilities focusing on stigma. And then at the facility level, they would be directly implementing activities to improve the way in which the facility functions. This can be done by uniting different streams of data, including clinical performance data, which can be disaggregated to see whether or not there are disparities in care among key populations, healthcare provider surveys that look at attitudes, beliefs, and knowledge, and of course, patient experience feedback. So we hear directly from people about what their care experience is like and whether there are problems that can be addressed. Quality improvement is a great strategy in which to act upon this information that allows us to focus on the system of care and achieve better outcomes. At the jurisdictional level, it's also important to engage the community, and there are now innovative strategies being implemented in which data can come directly from the community to inform the way that care is provided. Typically, community activities and healthcare activities related to stigma and discrimination are siloed, but they can come together. And in this example from Vietnam, we can see some of the strategies that help allow this to happen. One is the community scorecard activity, in which consumers and providers come together and rank and score on common measures, and then compare their findings and address them by coming up with interventions to target improvements. Having many strategies to get client feedback. This can be from hotlines or comment boxes, from exit interviews, focus groups with the community, and these can all help contribute to the community voice. Another strategy is to have a formal community advisory board in which consumers who are part of the facility help organize these activities, meet with staff, and help to bring back all of the information from these different sources back to the staff to work on improvement efforts and strategies, make the facilities both more friendly, increase privacy and confidentiality, and leading to better engagement in care and achieving outcomes. So to summarize what can be done at the jurisdictional level, we wanted to point out first that HIV-related stigma and discrimination in healthcare facilities is actionable and it can be reduced. Quality improvement is an effective strategy to improve healthcare systems and improve patient experience. Policies and legislation can be adopted to protect people against discrimination in all sectors, including housing, labor, health, and education. Community education with use of social media and advocacy can help educate the public and reduce self-stigma or internalized stigma. Contact strategies and dialogue can be promoted between the community and providers and policymakers. Leadership to combat stigma and discrimination can occur at all levels of society, and jurisdictions can convene learning networks and communities of practice, uniting the community in healthcare activities to eliminate stigma and discrimination and promote health-related quality of life. So thank you very much for your attention, and this concludes this module.